Okay, good evening everyone. My name is Kim White and I come from a company called EMIS. Who's heard of EMIS? Anybody know what it stands for? No? It's Egton Medical Information Systems. Egton is a place in North Yorkshire not far from Whitby, and it's called that because it was founded by two GPs, Peter Sowerby and David Staples, and that's where they had their practice. And that's actually quite important because the reason that they founded the company was because they had come up with some program solutions that enabled them to share medical records between their different locations and also take them on the hoof to visit patients in the middle of nowhere. And other GPs thought that might be quite useful too. That was 31 years ago. And both of them were still involved with the company as recently as 4 years ago. They've now both gone into retirement, turned their investment into cash, and they're putting it back into medicine because they have both founded charitable trusts. I just thought I'd mention that. Okay, can you bear with me, by the way? I'm a bit husky because I've actually got bronchitis at the moment. I'm halfway through a course of antibiotics. I think I'll last the talk. If I keel over, I'm hoping someone at least will know what to do about it. But I should be okay. I've got a couple of questions for you. I guess everybody, well, you all said that you'd heard of EMIS, so presumably you've heard of EMIS Web, and you'll know that there's a good chance that when you go to your GP, your medical record is held on an EMIS Web system. It's actually a web-based system running off a remote server farm, so your medical records are in fact in Leeds. They're in 3 different places in Leeds. Because of the high level of data security that's required around the system. And obviously, if that system went down and those records were not accessible, it would have a huge impact on medical care. But there are 3 companies that provide medical systems in that way. The other 2 being TPP and IMPS. They're also both in Leeds as well, which is also where HSCIC are, who are the people who develop IT strategy for the NHS. So Leeds is the place if you want to know about data. Now then, who here has heard of the patient.info website? Anybody looked up medical information, you know, cure for the common cold or whatever? Yeah, I know you have, Theo. Right, how many people were aware that that's a wholly owned subsidiary of EMIS? And it's a not-for-profit organisation. So that service is provided free of charge by EMIS. Anybody heard of Q Research? Q Research is a resource that you can access through the University of Nottingham, and it has the world's largest medical record database, over 1,100 GPs worth of data. So several million patient records. 68% of the longitudinal studies based on medical records conducted in the world are conducted in the UK. And the reason that they're able to do that is because there are 3 major databases of big data, of which Q Research is one. Don't ask me who the other 2 are, because they may have something to do with TPP and IMPS, but amongst others. But I wanted to let you know this, because this is an area in which the UK truly is at the leading edge. We started very early down the route of developing electronic medical record systems. And I'm not saying that we have the greatest in the world, because there's plenty of other good examples in other countries. But we probably have the most integrated system. For over a year now, TPP and EMIS have been working together so that their 2 systems will interface. That's 95% of all GP records are on those 2 systems. Just under 60% on EMIS Web, about 35% on TPP System 1. IMPS Vision is a slightly different kettle of fish because it's not quite as highly evolved system. But IMPS Vision, having said that, also do a lot of good work around research. So, you know, we have quite a lot of aces up our sleeves as a country. So, the world in which EMIS operates, fairly obviously, we're in the world of the NHS. Which is 60 million patients, depends on how you want to talk about the NHS, 60 million patients. It's 209 clinical commissioning groups. It's 9.5 GPs, it's 154 acute trusts, it's 26 health boards, it's 56 mental health trusts, over 200 community care organisations, and over 14,000 pharmacies. EMIS works with all of those, potentially, because you've got systems that engage with all those. And in that sense, it is unique amongst the medical system suppliers in the UK. It's the only company that has medical information system solutions which are pertinent to every one of those sectors. So what does that actually mean in practice? It means that we work with GP federations, primary and acute care systems, pharmacy clinical care, urgent and emergency care, long-term care, end-of-life care, and neighbourhood programmes as well. So what started out as two GPs developing a handy tool to make life easier for themselves, and their friends thought it might be useful to have a go at using it as well, that's what it's now become. It's a mega business. So EMIS nowadays is a listed company, and it needs to be, because that's the only way that it can get the cash throughputs, etc., to be able to continue to evolve its systems. So it's all about mobilising data. It's always all been about mobilising data. Back in the day when doctors, excuse me, Sowerby and Stables were setting up their first electronic records, their primary medical records were the old Lloyd George wallets, the paper wallets. You still find them, obviously, but that's all they had in those days. The trouble was that because they were written out by hand, you really only ever had one copy. And if a patient turned up to a different surgery, or you suddenly got a call out when you were halfway through a round, then what did you do about getting a medical record? So the early concept of interoperability was a very simple and rudimentary one. Interoperability is a somewhat more sophisticated concept these days, as I will hopefully start to explain in just a moment. It's about integration as well, though. It's making sure that there are some fundamental concepts in the way that data is actually presented, so that we have the same way of looking at patient information, and no matter where that person is in the healthcare system. Now, I'm biased because I work for EMIS, but common sense says your starting point ought to be GP records, because everybody's got a GP record. Anybody that's ever been ill, has got a GP record. Not everybody's been in hospital, but they've all been to a GP. So it makes sense that that is the anchor point around which all the other systems fundamentally work. And that's certainly the cornerstone on which the EMIS philosophy is actually founded. But it's also about patient empowerment, because if we are going to be able to drive the cost base of the health service down at the same time as we raise clinical standards, then we need to use patients as a part of the treatment regime. Now, that's something which is, I suppose, an under-discussed and certainly under-evolved concept at the moment. But I'm going to show you a video clip shortly, which I think will illustrate just what a difference that can actually make when you actually do it. So that's a cornerstone. And finally, a mobile-first strategy. Everything that we do is about taking healthcare to where it needs to be. So the data has to be mobile. The data's got to be able to arrive at the place that you need it. There's no point looking up data here and having to try to memorize it when you get over there. You need the data over there. Right? So that's also fairly fundamental. It's about having the right data in the right place in order that it's easily to hand. So take those things together, and they offer an almost unprecedented opportunity to change working patterns which will drive efficiencies and improve patient care. That's the common sense notion, but does it actually work? Well, I'm hoping that I'm going to be able to demonstrate to you a bit later on that actually it does, and it's not hard to make it so. Well, it is hard to make it so, but if your basic conception around those four dimensions of interoperability, integration, patient empowerment, and mobility are drivers of the way you go about it, it becomes a practical thing to actually achieve. And so, the reality of the world in which EMIS operates is, these are just some examples. Top left-hand corner, the heads of both EMIS and TPP signing a joint agreement to cultivate an interface between TPP System 1 and EMIS Web. And in so doing, although the architecture of the two systems is radically different, in so doing it becomes possible to go into an EMIS practice or someone using an EMIS system and to be able to access a TPP medical record or vice versa. That's the ambition. That's where this is going. Now, we're not quite there yet. There's a lot of testing needs to take place to make sure this is all functional, but we're a long way down the track. We've been working on this for over a year already. So, you know, watch this space. But there are things there like patient access to records. Now, I mentioned about patient.info. How many people were aware that patient.info is also a portal? Within patient.info, there's a part of that suite of programs. When you go into that website, there's a part of it that's called patient access. And if you enroll on patient access, through that portal, you can get into your GP practice. And you can schedule appointments, and you can order repeat medications. You can set up messaging service with your clinical clinicians, so you can have a running dialogue around your condition. And you can also access your medical record. You can even get access to test results. Okay, that's all part of that portal. And again, you will find there are equivalent systems being made available through TPP and IMPS Vision. I've got to be fair, right? We're all trying to do the same thing in that regard. Okay, but the patient.info platform specifically is EMIS, and through it, 60% of medical records can be accessed by the owners of those records. Note my use of the term, they're owners of those records, because that is open to some debate within the health service, who actually owns a medical record, the doctor who wrote it, or the patient about who it was written. Well, the law says it belongs to the patient, so end of as far as I'm concerned. There are things going on all the time in terms of the outside world, like, for example, Tech UK launches an interoperability charter for health and social care. And that's important because it's not enough for our systems just to talk to the NHS. They've got to be able to talk to adult social care, to community health projects, to local government, to public health bodies, and so on and so forth. And the vision at the end of the day is that all those kinds of public services will all be stitched together, so that a person who has need of whatever composite assembly of services across the public sector will be able to access them all. And those organisations themselves equally will be able to hook up and use information in order to support those members of the public. That's an incredibly ambitious undertaking, incredibly ambitious. But it starts from a will around those dimensions I talked about earlier on: interoperability, integration, mobility, and what was the other one? Can't remember. Whatever the four were. Okay. It won't be a surprise, therefore, if I say to you that not all solutions actually work out the same. CCGs are different. The nature of the legacy platform of IT that they have is different, potentially. The nature of the working partners they're going to have to work with are different. And so it's not a case of there's one right solution to how you build all these interfaces, and that's the way the whole of the NHS works. It would be great if it was that simple, but it's not. And so, for example, there are solutions in place, and solutions that we're working on, that use a portal approach for data exchange. So, for example, this is community child and mental health and out-of-hours services feeding into the portal, along with primary care, secondary care, and social care. So that's a fairly common model of the way that you could actually stitch the data together. But it's not the only one. Another way is the point-to-point approach, where primary care, because I said, if you remember I said earlier on, the common denominator is everybody's got a primary care record. So you make that the focal point, the hub, if you like, around which everything else interfaces. And there are projects going on up and down the country which are using that design concept for the way that the data is interlinked. But there are also these things called healthcare integrated exchanges. And this is a slightly different concept again. You have a database in the centre as opposed to a portal, and the data is fed into the HIE from all these different ancillary organisations, secondary care, social care, clinical services, primary care, CCMH and OOH again. So the architecture of the data and the way that the systems actually operate can vary quite significantly. But the key is the ambition of what the system is going to deliver is pretty much always the same. Right? How does a person being admitted to A&E and who may be unconscious at the time when they're admitted, how is it that clinical staff in A&E can access that person's medical record and find out about any medications they're already on, any allergies that they have, and therefore be more confident about the medical judgments they're going to make in order to treat that person in the most effective way under those circumstances? That ambition is fundamentally the same. But the challenges are met in a number of different technical alternatives. Okay, and a company like EMIS has got to be able to work around all of those different alternatives, not least because very often where we're dealing with a particular CCG, not all of the medical records are specifically EMIS web ones. And that's why being able to talk to TPP and IMPS Vision is so important. So, underpinning all of this is a philosophical position adopted by EMIS, which is an open API strategy. API is simply application program interface. So this is basically so an app will be able to talk to our system. Okay? And the whole point about an open API strategy as opposed to a closed one is that a closed one, only your own developers can develop a solution that will interface with your systems. If you have an open API strategy, other systems developers can have access to the spec of your system to enable them to build an interface. And we have a lot of prospective partners. I'll show you some of them in just a moment. Not prospective, but real partners. Technology should be seen as an enabler, not a barrier. I thought it was interesting, actually, before the professor just went out, raising Caldecott. Caldecott's really interesting because Caldecott 1 was all about data protection, about the concern that people should get hold of medical information that they shouldn't really be entitled to, and therefore it could be misused and abused and so on. Is it 14 years, 15 years since Caldecott 1? Something like that? We're still having that debate. It hasn't gone away. But what we should be focusing on is Caldecott 2. And Caldecott 2 is about being able to share information in order to best meet the needs of the patient. Right? So it is all about using the technology to enable patient care. We're enabling shared working through our commitment to interoperability and integration, and the best way that we can do that is by operating this open API strategy. So anybody that has a legitimate reason to interface with an EMIS system just needs to get hold of us, and we will sit down and talk to them, and we will give them all the spec information that they need and work with them to develop that interface, make sure it works. And to date, we've done that with over 60 different partners. So, our strategy is to adopt an open API model for interoperating with third-party clinical systems and to use the same mechanism to integrate and interoperate where technically possible. So, we're trying to make all of this look as similar as it possibly can be. And that's important because you, as clinicians of the future, need to know what it is you're looking at. And if it doesn't have some kind of consistency in format and layout, it's going to be very difficult for you to keep track. if you move from one part of the country to the next, there's a real risk that the same information appearing on the screen in front of you is going to look entirely different. And it's incumbent upon companies like EMIS to make sure that that's not the case, and that you're able to make sense of what you're doing. So we're committed to enabling customers to deliver better joined-up patient care. We're committed to integrating our own clinical systems to join up different health sectors, and we're committed to interoperating with any third-party health or social care system that conforms to our best practice open API technical and governance models. And it's a major part of our development activity, huge part of our development activity. So, open API interoperability involves mental health organisations, social care, emergency services, hospitals, community care, pharmacies, diagnostics and healthcare-wide. But there are different parts of the EMIS system suite. So we have primary, community and commissioning. Oops, didn't mean to do that. How do I get it back down again? Thanks, Martin. Cheers. I'll try not to stand quite so close next time. Existing EMIS health platforms, existing health system self-hosted, and EMIS health systems on premises. So there are lots of different EMIS type solutions depending upon whether you're a pharmacy, a GP practice. Okay, I've got that, Martin. That's very timely actually, because that's the last slide. I said we already work with a lot of different partner organisations. So these are just some of the companies that we already have interfaces established with. Okay. Now, not all of those will be found everywhere, depending upon what a particular CCG is invested in over the years. But that list is growing all the time. Have I got time to run the video?
I was diagnosed with rheumatoid arthritis in 2006 when I was 53, and ever since that time I've been on a broad range of drugs to control it. I have to say I'm doing particularly well. I get my treatment from the Swan practice in Buckingham and go there regularly for blood tests in order to monitor how my condition is.
Good afternoon, Swan Practice, can I help you? I'm looking into the beginning of April now for these sorts of appointments.
Here at the Swan Practice, we're quite a large practice. We've got around 20,000 people. We tend to do between 50 and 60 blood tests per day, and obviously we have other testing as well, and a lot of those people that we see are with long-term conditions.
I'm sure it's absolutely fine.
Obviously a key thing for me is getting the results of my tests. And in the past, before I went online, I had to take a small booklet down to the surgery for one of the nurses to fill out the results of the blood tests. And then I'd have to call back to the surgery a couple of days later and get these all-important results in order to get a snapshot of how my condition was going. Quite frankly, I think that process was certainly a nuisance for me, and I sense it must have been a nuisance for the surgery staff as well.
We started offering patient online access to test results about 6 months ago. We already had a lot of patients looking at various parts of their record online, and this was an additional service that we could offer them.
When I was first able to actually look at my blood test results online, it was fantastic because suddenly I could see the whole scope of my results when it suited me, find out, and that all the information was there. And to my delight, so too was the past tests that I'd had over the previous years of my illness. And that was just an eye-opening experience which really helped me to understand my disease and how I was managing it so much better.
A typical scenario where it would be really useful is a patient comes in to see me, we decide as part of their management plan to do some blood tests, and we have a conversation about how they're going to get those results. I offer them the option of online test access, and then I'll check their record to see if it's already there. If not, I can print them off a simple leaflet straight from my desktop and I can either sign them up myself or they go out to reception who'll just sign them up.
Okay, what you can do is register for patient access, which means you can look at your results from home at any time of your convenience.
Okay.
I go to a consultant outside the area, so she doesn't have access to my online results. But obviously I do on my iPad, and I take that with me to the consultation, and we can go through any of the results and drill down into them and see all of the results in context there. And that we're finding is working very well.
Some people like Graham are very interested in learning more about what their blood test actually means. We encourage them to look at a website called Lab Tests Online, which is really nicely written for patients, very clear explanations. We have a section on our website, and also the information leaflet we give out when we sign people up explains a bit more detail and sort of where to go to look for more information.
What's changed is that we have far fewer calls from patients asking us to give us information on their test results. Nowadays, they can get their test results online 24/7 from their own homes.
When I first explained to people how to use the online test results, they were quite excited about it. It means they don't have to ring in, they can just sit at home and have a look at them, and also then that they can explore what that result means for them. They find that really useful.
I think online test results is a brilliant idea. It allows people to take ownership of their medical condition. They can see areas that they might want to address themselves. They can look at past test results, so that when they come in for their consultation, they've got a better idea of things that they want to address.
One of the most important things to me about having rheumatoid arthritis is recognising the need to self-manage. And one of the most important tools in my self-management is the results, and having the results online, not only the current results but history, is a fantastic tool for me in that self-management process.